And a warm welcome back to Woundcasters, where we explore the truth by exploring the gap. And today's gap is a big one that people really don't talk about, but one that really needs to be talked about. And that is providing wound care in the home. There are so many people out there who are underserved and not served at all because they are stuck in their homes, and we don't ever talk about them because they don't come to us. They don't come to our clinics, right? We have to go to them. And for that, I have a wonderful, amazing guest today who does exactly that. Lindsay Lupton is a wound care provider who goes to the patient's home. And I think it's a wonderful opportunity to talk to her about it, how she got to be there and how she's doing it and what she's doing and what we all can learn from providing wound care in the home, how that differs from wound care in the clinic or the hospital setting, what the challenges are, whether that's clinical or financial from a reimbursement standpoint. We'll hear all about it. So with all that out of the way, let's get right into this conversation with Lindsay Lupton. So nice to finally see your face. I know we've had conversations before on the phone, but it's so good to see you finally. And I am just so happy to have you do this with us today. So why don't we get right into it? Who are you?
Well, thank you so much, Felix, for inviting me to the podcast today. It is truly an honor to speak about what I'm super passionate about, which is patients and wound care. So a little bit about me. I am a registered nurse, graduated in 2004 from Cleveland State with my BSN. And I was at first in the critical care space at the hospital, and I learned a lot about people who are gravely ill and critically ill. I did last about 2 years in that high adrenaline setting, but I learned that that's just not how I'm made, not how I'm built. I'm not called to the acute, critically ill patients. So after about 2 years, I was blessed to get into home health care. And that was a very eye-opening experience for me. I had only been a nurse for 2 years, and I had this very pie in the sky concept of what home health care would be. In my mind, I had spent the last 4 years at a university learning how to be a registered nurse, and just the amount of responsibility. And it was really interesting to realize that at home, these patients do not get the quality of care that they should be getting, that there were gaps in our healthcare system. There weren't enough staff members to go to the home. And if there were staff members available, how were they going to get paid to get to the patient? If it wasn't covered by insurance, the patient would have to pay out of pocket for caregivers. And it was, like I said, it really burst my bubble. Because I think maybe being young and novice, I didn't realize that our healthcare system, somebody has to, at the end of the day, be responsible for the payment. And if there's no funds available in our healthcare system, the insurance won't cover activities of daily living and that sort of thing. It was relying on the family. And that was the role of the registered nurse in the home for home health care, was to teach the primary caregiver how to be a nurse, basically.
Right.
So, yeah, that was a very eye-opening experience. Like I mentioned before, being in the university, I was taught sterile technique of how to care for wounds. I was taught sterile technique of how to do an IV PICC line dressing change and how to operate the IV pump. And here I was, I'm teaching all of this to a lay person, to the wife or to the daughter. And I was just blown away. In my mind, it should have been a licensed professional that was providing that in-home care. And here we are, we're teaching, the family member to do it. So that was the first thing that I realized. The second was,
and I'm sorry to interrupt you here for a second. I just want to clarify, at this point in your career, you're still a generic nurse. You're not in wound care yet. So when you're doing these home health things, you're doing medication administration, churning, bathing, toileting, all those generic nursing things, not specific to wound care. Is that correct?
That is correct.
Okay.
Yes. So I was the all-purpose registered nurse, teaching about, high blood pressure, teaching about diabetes, heart failure, edema, daily weights, that sort of thing. And then there would be home health aides for bathing assistance. So if the patient was admitted under home health care, the home health agency receives a lump sum payment, and that includes anything from physical therapy, occupational therapy, speech therapy, social work, registered nursing, and a home health aide. But that is once a week, twice a week for those skilled clinicians to go into the home. And the rest is on the family member,
right,
to take care of that patient. So if the patient should be under Medicaid, then that does open up things like Passport, where they can get a non-skilled home health aide. And that's where you get the help with toileting, transferring, light housekeeping, shopping, stuff like that. Okay. But when we're talking about skilled nursing care, it's very limited. There are a lot of constraints financially, on both sides, for the home health care to send the clinicians out there, and also the insurance, what they're willing to see as a skilled need versus custodial needs. So when it came to wound care, I was compelled internally, intrinsically. I had this desire to learn as much as I could, because the patient and family were looking to me for answers. And I didn't know how to treat wounds except a wet to dry. That is what we're taught at the university, and it's sterile technique nonetheless, and in the home care setting, it is a very uncontrolled setting. You have a cat, or you have a dog, or you have no lighting, or you don't have supplies. It's not like you can go to the storeroom and there's gauze and saline on the shelf. Sometimes there's very limited supplies or resources. So at that point, I was just, like I said, compelled to learn as much as I could about wounds. And I hit the books, anything that I could get my hands on just to learn. And any other mentors, there were some mentors that came on the scene immediately. My wound vac mentor was Luann Boyer. She is a WOCN, and I hadn't even heard that term before. I never knew what a wound ostomy continence nurse was. And I was inspired by her through and through. Luann took me under her wing, and we had a patient together, and I didn't even really know how to put a wound vac on at all. I didn't know the mechanisms of action. I didn't know anything about it. And this would have been back in 2006. And so Luann was the rep for the KCI wound vac. And she was like, what about why don't we ask the doctor to put this on? And it was a foot wound on a diabetic patient. He had peripheral artery disease, and he was end-stage renal on hemodialysis, so very compromised. He had had a cabbage. He had had fem-pop bypass. So his feet very at risk for infection and amputation and delayed wound healing. So we went together with the patient to the podiatrist's office. I'll never forget. And we asked the doctor if we could have an order for a wound vac. And he agreed, he obliged, and ordered the wound vac. And there we were at the house. I'll never forget, I was sweating. I had beads of sweat coming down my forehead just because I wanted to get it right for this patient. And I had Lou right there. And it was incredible. We got the seal, and it was right up by the toes and everything. So a very difficult vac application. But Monday, Wednesday, Friday, Monday, Wednesday, Friday, week after week after week, and seeing the fruit of my labor and faithfulness to this patient every single Monday, Wednesday, Friday to change the vac, and it did heal. And boom, I was sold. I was just ecstatic because here was this guy that had this wound for years and it was non-healing. And then here comes this mentor, Luann, and she gave me the tools and the knowledge to close this patient's wound. And it was on from that point.
And this was at home too, right?
It was in the home setting.
This was in the home setting. You were not in the clinic. And that's really when the bug bit you.
It did. Yes. I got the bug. I got bit by the wound care bug there. And then just moving forward, more and more patients. And I've heard it said statistically, there's 1/3 of every home care agency, 1/3 of those patients have wounds. That's their admitting diagnosis. So about 1 in 3 patients has wounds. That's a lot of people.
Yes.
And so as the time went on, I had more challenging wounds. I didn't know what to do for them. And in the Cleveland area, I was Western Cuyahoga and Lorain County, and there was a wound center. But even at that point back then, there weren't all of these wound centers. There was only one that existed in the Lorain County, and it was too far for my one patient to travel. And so again, I was at a crossroads. What am I going to do for this poor patient that's in extreme pain? She's diabetic. She had a heart attack. There weren't a lot of resources. The patient did not have a lot of funds for transportation to get to this wound center that's far away.
I think that's an important point to make here, why there are so many underserved people who are stuck at home, because transportation for many of these people is not cheap. These are people that are bed-bound, wheelchair-bound, limited mobility. They require a lot of assist for transfers, and even getting an ambulette and physical help is a lot of work. Sometimes that can take an entire day for a 15-minute wound care visit, or even if it's half a day for a 15-minute wound care visit at the clinic. So I think that's an important point to make here, that is one of the reasons that this is such an underserved population. They have limited resources and they don't have access to the transportation for them to come to us as much as we would want them to. They just simply can't.
Absolutely. Yeah, I remember her specifically. Her husband even had disability. They're both elderly, so it's not like she could rely on her husband. So this patient with peripheral neuropathy who can not feel her feet, they did actually, as luck would have it, they opened a wound center in Elyria, which was down the street from her. And she did have an automobile, so her foot wound is on the right foot, of course, which is where the gas pedal and the brake is, and she's got neuropathy. So for her to be driving to the wound center was pretty precarious, not optimal, not ideal at all. But we did it. She did get to the wound center, and at that point, it was brand new wound center. They had just cut the ribbon, in the opening day. And I went in there and I was like, hey, I have this patient that needs you guys. And how do I get a referral? And by the way, are you guys hiring? And they did have an opening for me. And so I left home health and was blessed to work at the wound center. And they sent us to Conroe, Texas. And before Healogics, there was a company called Diversified Clinical Services. And that's kind of where you drink from the firing hose of wounds. It was very intense, week-long training on the clinical guideline CPGs, their clinical pathways.
Mm-hmm.
So if a patient had this diagnosis, this wound etiology, you did this schematic. You would set the patient on the course for, a diabetic foot or venous stasis or a pressure injury or a complex surgical wound. You would categorize based on etiology, and then there would be a guideline so that you could have the same outcomes and very high outcomes. And we were graded on our outcomes. It was a wonderful learning. I learned about hyperbaric oxygen, TCOMs. That was where it was born, my desire to get my certification in wounds. I sat with some of the greats, plastic surgeon, Dr. Roland Reyes. He's an incredible mind, and his ability to heal wounds unmatched. And I was able to go, like in the Cleveland area back in the day, Dr. Quan Lee, Dr. Keith Warner. These were big names in the Cleveland area for wound healing. And Dr. Lee and Dr. Warner got together and created Northeast Surgical Wound Care. And they're general surgeons, and they had hired some nurse practitioners to go into skilled nursing facilities and long-term care, acute care hospitals, LTACs. And I was able to, after the wound center, I landed a job on the wound team at an LTAC, and that's where I met Mary Ecklinger. Mary Ecklinger was a nurse practitioner. She's retired now, but she really was the backbone of Northeast Surgical. Mary Jane Maloney and Marianne Ecklinger. And I was trained under them. They were workhorses, really, honestly. At the LTAC there, it's like a 35-bed hospital, but almost everybody has wounds, and not just one or two. It's the entire back surface, their scapula, their head, their trunk, their heels, both trocaners, because they're reliant. They're chronically critically ill patients.
Right.
So chronically critically, meaning if you take them off the ventilator, they won't live. If you take them off dialysis, they won't live. If they're taken off tube feed, they're not going to live. So they're chronically critically ill. And what happens is, they're bedfast. So they have wounds all over. And it was just an amazing opportunity. And I was their understudy, truly. And I just couldn't get enough. I learned, and I did sit for the exam for the Certified Wound Specialist, CWS, through the American Board of Wound Management. That was my first exam, was in 2012. So at that point, I was just an RN, and had this just internal drive to become an expert and help these people, preventing infection. If we couldn't heal the wound, at least prevent it from getting worse and causing sepsis and that sort of thing.
Yeah.
So,
the fascinating thing about your story, and I think this really is worth highlighting is how much of a team effort wound care is. You did not do any of this by yourself. You had the right people by your side, the right mentors to guide you, and that's really ultimately, I think, what helped you succeed in this space. And I think that's really an important point to highlight how much of a team effort wound care really is. We have to rely on each other. It's not just about the nurses, it's not just about the doctors, it's not just about the therapist. It's all of us coming together as a team to treat the patient as a whole, and not just the whole, the patient, as people
Absolutely.
usually say, right? I think
Yes.
you're not self-made, if you will, right? You had all these phenomenal people to guide you and show you the way, and that's really what shaped you and got you to where you are today. So that's an important point, I think, that needs to bear mention. So you're in this LTAC space, and I've been in the LTAC space before. I absolutely agree with everything you said with the ventilator dependence, the dialysis dependence, the tube feed dependence, the antibiotics that are infusing, 24/7. So how did you end up coming full circle and going back into the home?
Yes, it is full circle. It's very ironic. So from there at the LTAC, I was so sold on the KCI wound vac, but it's the most expensive, right? It's the Cadillac of negative pressure. And so to cut cost, there would be other vendors that would get the contract from the LTAC company. And my manager was so wonderful. She respected what we were doing so much, and she could see the quality that we were bringing to the table, that she would go to bat for us, and she'd be like, okay, Lindsay, I have to satisfy corporate and use this device. But if you can show me clinically why it's not right for this patient, then I'll let you use the KCI. So, of course, I would oblige and put it on, and we would have subpar outcomes. The tissue quality was pale pink. It wasn't that strong, robust, beefy red bleeding tissue that you get with the VAC. And so what ended up happening is the rep from KCI. So at this point, Luann Boyer, who was the KCI rep, she had moved on to other things in the wound care space. I think at that time she was doing a e-stim or something. But anyway, Lou had moved on, and that opened up for another rep to come on the scene for KCI. And that rep took a notice of me because I was basically selling his, he was the sales rep. So I was selling his product to my manager. And that really, woke him up, as like, wow, what is this all about? And it was because I had seen the difference, that you could not tell me that was the same product. It's not. The sensitivity of the VAC, it has that track pad, and the others don't. So it could monitor the pressure at the wound bed, not just at the pump. And you could see that clinically. So anyway, I was approached by the rep, and he said, you should really think about coming on board with us. We are hiring, and I think you'd be incredible at this. And it was a great opportunity, but at the same time, very scary, because I didn't know anything about medical sales. I had only been trained as a nurse. I didn't know anything about business. And he assured me that he would take me under his wing and teach me the ropes. And so the walk, the leap of faith. And I left bedside nursing, and I went to work for KCI. And his name's Jared Zavoder. He was true to his word. And for the next decade, he taught me how to speak and talk the talk and the lingo in the business world. And again, my eyes were opened about the healthcare system and that it really does come down to cost containment, and but at the same time you get what you pay for. And it was a lot. It was a lot of learning. But I also at the same time was again afforded the opportunity to meet so many more people that were doing wounds, and to come alongside them and teach them about my beloved VAC, because it is the game changer. It's the only thing that we have that will actually create tissue. You know, all other wound modalities that we have will help the body create an environment that it can heal on its own timetable and own trajectory. But the accelerated granulation tissue formation with the wound vac is in a class of its own. And on the flip side, you could actually do the patient a lot of harm if you don't know how to put it on correctly. So I do like to teach, and it was just the perfect harmony of helping educate and bestow all of that I had learned to other clinicians, because I'm only one person, so I can only treat that patient right in front of me. But if I could equip and educate nurses and doctors and NPs and PAs about wound care, then I've helped that many more people. And I just have this internal mission just to raise the bar, raise the standard of care across the continuum when it comes to wound care, because I remember what it was like not knowing. I didn't know. All I had was a saline and gauze and some paper tape, and when to use an alginate, when to use a collagen, when to use negative pressure, compression, just getting down to the nitty gritty, and then helping take what I've learned and give that away to somebody else. It was wonderful. And
that's a force multiplication effect, right? You're multiplying yourself so that there's more of you available. And that's, especially in the home healthcare space. I mean, I'm kind of curious to know what your insights are here, because I have some experience with it, but for me, especially on the home health side of things, there are a lot of nurses that are around that go into people's homes. There aren't enough. And the ones that do go around oftentimes don't have that wound care experience that you and I have. And so there is substandard care that's being given because, like you said before, all we get taught are wet to dry dressings, right? I mean, when I was going through my surgical training, and this is something that still boggles my mind, right? As a surgeon, I'm trained on how to create wounds, but I'm really not trained on how to heal wounds. And I would say probably the most advanced wound care dressing, other than the wound vac, that I was taught in my residency, in my surgical training, was calcium alginate. And which is just not knowing what I know now. It just boggles my mind that I'm trained on how to create wounds, but not on how to heal wounds. And so there is a huge gap in knowledge on how to heal wounds, and especially in that home health setting. And so for you to go out there and say you educate and you help other people learn the things that that force multiplication effect is so important, and we all need to do that. It's not about taking the work away from us. It's really sharing the load, because there is way too much for any one of us to handle in a given day. So we need other people to have this knowledge, to learn, and to be equipped with the right knowledge in order to treat patients correctly. So that's kudos on you. I think that's fantastic. I think we all should be doing that.
Yes, I agree. Working for KCI, I did have the opportunity then to go back and get my NP. When I was working at the LTAC, I did get some expertise, I would say, and the physicians did trust me. So they would let me write the telephone order or the verbal order, and they would sign off on it. And the one nurse, Marissa, she was a nurse practitioner with infectious disease. She kind of took me by the lapels and was like, when are you going to go on and get your NP? She's like, you're already doing it. You're just putting it as a telephone order, you're already writing the orders, so to speak, is what she said. And then that really dawned on me. It's true. Why don't I just go? And,
Sure, let's
Casey,
do it. Yeah.
let's do it. So I did go back, graduated from Ursuline in 2014. And so I had been an RN for 10 years and then went back and got my NP. And I'm ready to prescribe. But at that point, I did have kids. So life, I didn't have the bandwidth to be a prescriber yet. And I decided that I would stay at KCI because I really did love what I was doing. I was in the home care space and I was teaching the nurses as much as I could. There was a merger, and 3M and KCI merged together, and there was a duplicate role. So the post-acute representative position, there were two of us, and at that point, I was let go. It was painful. But I was meant to be doing patient care. So at that point, I was like, wow, okay, that era has ended. Turn the page. This is a new chapter in my life. And now I'm ready. And I worked at Medina Hospital and did their wounds. And I was again offered this amazing mentor, Ann Vetter. She's a physician assistant. She was trained in general surgery and plastic surgery, physician assistant. And, she's just right there in my lap. And she took me by the hand and showed me how to do a biopsy, showed me how to do an incision and drainage. She expanded my ability to debride. And, she just equipped me even more. And it was, like you said, a team effort. My infectious disease doctor, brilliant. My general surgeon, when it's beyond what I could do at the bedside, them taking them to the OR and doing the debridement, or them trusting me with a very complicated patient. And me saying, Doc, if you'll take this patient and excise this big belly necrotic area and give her back to me, I can get it closed. You know what I mean? Like just that kind of collaboration. I mean, and we did it, it's exciting stuff. And that patient, that loyalty to the patient, though there are some long valleys that these poor patients have to go through because their sugar, their A1C is 11, and they're allergic to this and they're allergic to that, and they're scared and they're trusting you. And, there's months sometimes that it takes them to heal because they're so compromised. They're morbidly obese. There's poor vasculature, that sort of thing. And then when you finally get it closed, I mean, you just want to ring every bell and, the hugs and the tears, and because it's this teamwork, not only with the surgeon and the other nurses, it's the patient. They are digging in their heels and they're with you. It's just, for me, there's no other way to, live. This is what I'm made to do.
So at this point, you're back in a hospital setting though, right? You're not in the home yet. So how did you end up coming around and getting back into the home setting?
So my desire was to be in a wound center because that was my roots. One thing, and this hopefully is not offensive to anybody, but wound centers, to me, they should be WOCNs, that every nurse and provider in there should be wound certified, because it is its own specialty and it's a whole different set. It's not just infectious disease. It's not just vascular surgery or general surgery. It's exactly what you said. They're surgically trained, they're medically trained, but are they trained in wounds?
Right.
Not always. So for me, I wanted to get back in the wound center and raise the bar again and have every nurse be certified in wounds. It couldn't just be a nurse that you pulled off the floor and plugged in. This should be an expert, or this podiatrist should not just be a new grad that just finished podiatric residency and you plug them into a wound center. To me, call me having high standards or whatever it is, but that's not good enough for me. They should have to go through certification and specialty training to say that they're a wound provider at a wound center. So that's kind of where I was at. And those ideologies, if you will, it may be a little tough. I want to say it diplomatically. My morals and values didn't quite align with what is happening at the corporate level of a hospital system. And I found out that I really didn't fit into that kind of corporate mold. How do I want to say? There were restrictions placed on me. So I just felt like I didn't quite fit in there. And so I did a little soul searching. I left that position, and the opportunity came back full circle for me to do home care. And it is, I would say, less about the corporate and it's more about the patient. It's not about volume, so to speak. And I had a physician that was open to produce this mobile arm of her practice. And so we launched it in September of 2024. It's a mobile wound clinic. So it's everything that I've learned about superior expert wound care and bringing that to the patient's home, that kind of high caliber quality.
Yeah.
And so, that's what we're doing right now.
Yeah. And so let's talk about that, because that's the fascinating part of your story here, is that you are a mobile wound clinic, as you say. And like you alluded to earlier, if you are in a clinic setting, you have that wonderfully stocked closet with all the gadgets and gadgets and whatever you have, so that as you're going between room to room to room every 15 minutes, seeing a different patient, if you need something, it's right there for you. But when you are on the road and you go from patient's home to patient's home, and you are in those resource restrained environments, how do you handle that? What do you do about all these supplies? How do you deal with that?
So for cost containment, I use basic things in my nursing bag. So gauze, ABD, rolled gauze, Curlex, what have you, and tape. That's the major thing. When they're under home health care, the home care agency needs to be supplying the dressing supplies, the wound care supplies. So it can get challenging. I am not going to lie or pretend that patients have what they need. They don't. I have gone to a store and I've bought things, from Drug Mart or Target, out of my own pocket, because there's a need. And the home care agency, of course, is worrying about their cost containment. So there are some gaps. It's a problem. The patient, if they're not under home health care, then that does open up the opportunity that I can submit an order right to a distributor or a DME company, and they will bill the insurance company and send the supplies to the patient. But those are few and far between. Most of the patients are under home health care.
Yeah.
So it can be a challenge.
No doubt. So, how do you handle some of the little procedures that you might do in a home health setting, like debridements? Do you bring scalpels with you or curettes? Do you have silver nitrate on you for, on the one hand, bleeding control, but on the other hand, also for granulation tissue that may need to be cauterized? Do you have stuff with you to do biopsies in the patient's home? Like, what are your limitations really? And I'm partially curious about this myself because I have the way I've been trained, and the way I've always trained myself is, in terms of any surgery, as long as I have a scalpel and some 3O silk suture, I should be able to do anything. So I've always trained myself to be in a limited resource environment so that I can do almost anything, even when the resources aren't as fancy as they might be at a large academic hospital. So how do you handle that with some of the other stuff that we do in a wound clinic, like debridements, cauterization, Unabuda application, right? How do you handle all those things in the home?
Well, it's the same as what you said. You want to be able to trust your own abilities and know your limitations. Do I suture people? No. If I'm going that deep, they should be in the OR or a controlled setting where there's, some cauterization, electrical cautery. I do have, the silver nitrate, the chemical cautery, and direct pressure, and some hemostatic dressings, of course. But yes, I definitely make sure that I know what's too much, so that I'm not going to put the patient at risk. But yeah, I carry with me the punch biopsy, sterile disposable instruments, scalpels, and curettes, um, some forceps, things to do the debridements. And then there's a sharps container that I have in my bag. So all the sharps leave with me. And I set up it's not sterile, of course, but it is aseptic. So I'm not cross-contaminating. If, I'm using clean gloves and sterile instruments, but, the gauze itself isn't sterile. There's no sterile field. I don't have sterile drapes or anything like that. It's much like the wound center where it's aseptic technique. I do use some topical agents like chlorhexidine, betadine, alcohol, isopropyl alcohol, those things to clean the site.
Mm-hmm.
And, but yeah, we're able to do platelet-rich plasma in the home. We started doing that, and that's incredible. You're able to do the phlebotomy and collect the patient's whole blood, and then spin it down, extract the buffy coat, the plasma, and in there are the platelets and the growth factors, and then you mix it with the thrombin and the calcium, you
So,
create a nice little gel.
so you carry a
It's exciting.
centrifuge with you?
Yes. So at this point, we are branching out because in January of 2025, there is now reimbursement for it, for diabetics and diabetic wounds. So yes, now that there is payment for it, we can do it in the home setting. So now we're in June, so we're 6 months into this, and we did our first one on Monday. So the rep met us at the patient's home, brought the centrifuge, and obviously we are a startup company, so I want to be mindful that what the rep says is true, that this is what Medicare will reimburse, and because obviously we don't want to lose. I want to be able to provide care, so I need to be mindful and cognizant that we're being fiscally responsible. But yeah, it's super exciting because I've done it in the LTAC, I've done it the PRP, and now it's available in the home. So once we see that it's reimbursable and beneficial clinically, then yes, we'll have our own centrifuge and the kits to do it. So it's exciting.
That is really cool. A friend of mine does PRP for a variety of mostly joint abnormalities, let's say, whether it's some arthritis or plantar fasciitis. Um, but in the wound care world, the few times that he has done it for me on wounds, I've been a little underwhelmed by the outcomes. So what wounds do you use PRP on? Is it truly just diabetic foot ulcers at this moment, or are there others that you're looking to use PRP on?
So it is indicated for diabetic. They have to have that diagnosis in order for it to be covered currently. But what I have seen in the past is we used it on a pressure ulcer,
Mm-hmm.
and we could not get anything else to heal this gentleman. He was so compromised. He was a type 1 diabetic, so a juvenile onset diabetic, insulin dependent, and he had stenosis of his arteries everywhere, so cardiac and his peripheral arteries, diabetes. So he had to have bilateral below the knee amputations. And when he was on the OR table, somehow there was a spinal cord impingement or malplacement of his spine. And post-op, he came out paralyzed. So
Jesus.
yes, it was not a good situation. And he was only in his early 50s. But he had the pressure sore on his sacrum, and we had done so many things: Regranax, collagen, alginates, debridements. He had a hospital bed. He had a devoted caregiver. And it wasn't until we did the PRP that we finally got it to close. So it was his own growth factors. So
Yeah.
I was impressed. So I'm a believer.
No, I have not given up on it. It may very well be for me been patient selection that has led into that. So I've not given up on it. It's a very limited experience that I've had with it. So I think it's fascinating that you can do that at home. What other challenges do you see in the home? Like, if you could snap your fingers and be like, I wish this would just go away as a problem in the home health space, what would it be?
The utopia, right? Honestly, I think it's the ADL assistance. The picture is it's dire because you have an elderly couple, right? They said I do years ago. So they've been married for 40 years, and now they're both declining physically. And one perhaps is a total care, had maybe a stroke, and they have right-sided residual, and they're completely dependent on the elderly caregiver. And it's too much. Yet the nursing home isn't an option because they would have to sell their home, liquidate all their assets, and pay out of pocket for custodial care. So in my mind, there needs to be caregivers, more nurse aides, so to speak, that can help. We need to be able to bring into the patient's homes equipment. And even that is a challenge because the mattresses, I don't know if you've run into this, but back 10 years ago, mattresses were paid for by insurance companies. They no longer pay for an alternating low air loss mattress. So it's really getting difficult. And patients are going online and they're buying their own alternating low air loss mattresses.
Right. And
So I
oftentimes
think
they don't know what they're looking for. Whether that's buying the wrong mattress or a used mattress that no longer functions as well, or who knows what, but they don't have that clinical background that we have to make the right decisions there. A lot of times, which, it really showcases the kind of rock and a hard place that these people are stuck in between. I mean, I think there is definitely a push to keep people at home more. We see this with shorter hospitalizations, trying to push people out faster. We're seeing it with people not able to afford nursing care in a skilled nursing facility. So there's definitely a push to get people to stay home more. Actually, one of the
Yes.
hospital systems I was at, they even tried for maybe a year or two an ICU at home. So the people that needed hospitalization, but were stable enough to be remote monitored, they were tried at home, and they had EMS come and check on the patient 2 or 3 times a day, and everything else was remote monitoring. The biggest problem with it was reimbursement, because the system
Mhm.
just simply isn't set up for it. And I think that's kind of we're just on the cusp of this, where I think reimbursements in the home health setting are still low. And that's what's probably preventing a lot of people from doing more home health care. But we're also at a tipping point where we're trying to keep people out of the hospital and we're trying to keep them home more. So what do? Right? We're trying to keep people at home, but we're not going to pay for people to see them in the home. So for anybody who's listening to this, who is interested about the space and feels obligated to take care of people in their homes, just like you have, they feel a need that is an unmet, underserved community. What are some of the pitfalls or challenges that you have encountered that somebody should be aware of before they go into the home health space?
I think educate yourself and have a good network of nurses and other providers that you can ask questions. Um, know that going into the home care setting, you are everything to that patient. You represent the medical community to that patient, and they are going to look to you to solve every one of their problems. Um, and so it can be overwhelming, but hopefully the real McCoy, the person that came into nursing, or the caregiver role, that they're sincere and will do whatever's necessary to advocate for that patient and that family to get the support that they need. At the end of the day, just do unto others what you would have done to you. Try to put yourself in their situation and do what the patient needs. Put
Right.
them first, and
Well, that should be a
but it's
given,
challenging.
ideally, anyways, right? Put the patient first. But you bring up a good point, and I don't know if you can comment on this, but maybe a few little insights would be beneficial. Because if we go to people's homes, we see how they live, we see where they sleep, we see where they watch TV, we see how they keep their food, how they make their food, maybe. We see the water supply that they have at their homes. We see the social support structures to some degree that they have. These are all aspects of care that we don't get to see when people come visit us in the clinic. Um, but the caveat to that is, like you said, you are everything to that person when you go to their home. And that can be incredibly time consuming, which is one of the reasons that home health is so underserved, because you can't see 4 patients an hour, and bill for 4 patients an hour by going to somebody's home, because you might spend an hour or two at their home. So how do you deal with that? How do you deal with the tug between being able to provide enough time, quantity and quality, to your patients in the home, but also having enough quantity of patients to see in their homes in order to have a viable business practice?
So the biggest thing is the communication with the home health nurses. So they are an extension of me. So picture the hospital setting, the patient's in the bed and the provider goes and sees the patient, comes up with the treatment plan, writes the orders. Then there's some communication between that provider and the bedside nurse. And then the nurse carries out the orders. That same model is what I try to create, in that home health care nurse, I know her by name. She knows me by name. We have a direct communication to each other, so that she knows what I'm thinking what the plan is, what her role is, his role, as far as the wound care. And they keep me informed as the progress of the wound or the deterioration of the wound, the status of the patient as a whole, what the needs are. It's very tight communication. So I do not try to be all things to everybody. I definitely let them know how valuable and vital that they are. And I think they feel that, and it inspires them to feel empowered. It's definitely, I guess maybe where I came from, being the home healthcare nurse and seeing the challenges of getting to the provider. It was hard because you'd have to call the office, speak to the secretary, then the secretary takes a message, gives it to the nurse, then the nurse calls you back, and then the nurse says, I'll call you back after I talk to the doctor. I mean, it is this, and by the time you're there, it's like, well, you missed a whole day, and you still don't have answers for the patient. So for me, I streamline the process. Those direct caregivers have direct access to me, and it's a exponential effort on all of us, if that makes sense. So there's usually an RN case manager, and that RN has an LPN that'll do the visit. Yeah. So it's a team.
Right. And so I think the important thing, the important keyword here is communication, which is something that is poorly done in healthcare in general. Even though we've been talking about communication being at the forefront of medical errors for decades now, we're still talking about this in 2025, that communication is something that we can all improve on. So our time here is coming to an end. So I do want to ask you a last question, though. You have come from the home, you have experience in the acute care setting, the long-term care setting. You've been on the medical sales bandwagon as well in your career. You've been through it all, right? You've had the gambit of experience throughout all sectors of healthcare. What's the next big thing in wound care that you foresee? What's the big breakthrough that's going to come? What's the tipping point that we're at the edge of? What's the next big thing that you think is coming in wound care?
Oh my. I really think stem cells, the placental grafts are amazing. I've seen one application close a wound.
Sure.
And I'm really excited. I feel like we are living in an incredible time where we used to have to take the patient's own skin, create another wound, and transplant it to close the other wound. And, we don't have to do that anymore. There's tissue banks and, the value of the placenta. I mean, so yeah, I guess that would be it for me, is watching the science.
Yeah.
And,
that's wonderful. No, and I agree with you. Obviously, as a surgeon, I've been trained in skin grafting. And I think the idea of having tissues that we can do to replace that, because like you said, a skin graft creates a second wound that oftentimes is more painful than the first wound that we're trying to heal. So creating a second wound is always, it has its own disadvantages, let's say. So I think having those external growth factors and tissue matrix in order to heal wounds without creating a second wound is definitely something that is the next big thing in wound healing. So I can agree with that. I think I can see the world the same way as you do. So awesome. Well, thank you so much for this conversation, Lindsay. This has been absolutely wonderful. So many great insights into your career, your history, the world of wound care in general, where you've come from, where you've been, and what you're doing now. And I hope anybody listening to this can be inspired by everything you've done and turn that around and bring that around to their own world of wound care, be a force multiplier themselves, spread the word, educate others, and hopefully we can take care of more people better by doing this, because this is exactly what we're trying to do here on this Woundcasters podcast, is to spread the word, spread the knowledge. It's exploring the truth by exploring the gaps.
Thank you, Felix. Appreciate it.